who came to the care, those who came to one of the earlier talks I gave, the statistics are pretty dire. In husband and wife couples 60 and over, the caregiver dies before the care receiver 50% more often than the reverse. So people that provide caregiving services past 60 can really wear out and get sick. So this program is designed to give them support and give them some relief. And then finally, for the first time in my memory, the state is actually funding some basic legal document preparation for folks. If you're 60 or over, or have someone in the family diagnosed with dementia, you can call this number or go online and get set up with a legal representative who can help you do powers of attorney for financial health care, living wills, dementia directives. This is probably $300–400 worth of services that's available now for free. So I would strongly suggest that this is something you haven't had done, want to do, please call this number or go online and make a request so they can get someone in touch with you about that, okay? Any questions on programs highlighted? It's all on the table back there, so feel free to grab it. And then we'll get started. Okay, so I think we're good to go.
We're officially good to go online.
Okay. So we have the Medicare handout. I apologize, I think we might have run out, so I'll make sure we get you one. And then we're going to do Medicaid second. So everything that's on the screen, you should have in the handout as well. So. Okay, that's working. Great, excellent. Okay, so apologize for the technical difficulties. It sounds like we got it figured out. I hope people can hear me online. And if there's questions in the room, just raise your hand and we'll do questions as we go. So I think we have plenty of time to do that. And I talk pretty loudly, so I hope everybody's hearing me in the back there. Everybody's hearing me. Okay, so Medicare 2024, that's why we're talking about it in next year's terms, because fall open enrollment is coming soon, October 15th to December 7th. My name's Matt Santelli. I work as the Education and Outreach Specialist at Pierce County Aging and Disabilities Resource Center. That's a government office designed to provide basically one-stop shopping for topics and programs and services related to Medicare. Okay, so we're going to talk Medicare first and go through that presentation, and then Medicaid. One thing I'll always remind people is that the two terms get confused a lot, especially in media. So you'll be reading a journal article or some sort of posting and they'll use the terms interchangeably. They're not the same thing. Medicare and Medicaid are two very different things. And we'll talk about the difference first with Medicare and then later with Medicaid. I always give the disclaimer when I give the talk because everybody's Medicare situation is different. It's really a unique product. Now, I wouldn't have said that 21 years ago when I first started to work at the county. I'd basically be telling you, you have your Medicare A and you have your Medicare B, and that's it. You basically had the same coverage as your neighbor, and that was true across the board. They made some changes in 2006, I believe it was, when they added prescription drug coverage to Medicare. So back in the day when I was doing this job, a lot of what we did is do financial assistance programs for seniors to pay for their medications. So like I said, Medicare is as good as it's been since I've done this job. And those days were very, very difficult because you'd have a senior on insulin, and insulin can be very expensive. You'd have a senior on cancer medications, and they didn't have any coverage for it. I mean, so we're living in a different world, a much better world, that we do have prescription drug coverage on Medicare, because it didn't used to be that way. So with those changes, your situation's unique, or the family member you have on Medicare is unique. So you might have your Uncle Phil who says, oh, I got this great Medicare Advantage plan, or your Aunt Sally, oh, I got this great prescription drug plan. You should be on it too. Has nothing to do with your situation, okay? Everybody's situation is going to be different. And that's why we're going to review what are the questions you need to think about when you're getting Medicare marketing information, because those of you on Medicare right now, every Advantage plan, every D plan has your contact information. So you're going to get a mailbox full of these mailings about different Medicare products and services. And that doesn't mean they're good or bad for you. It just means they're trying to sell you a product. Okay, so we always So you should soon be getting this book with 2024 on it. This usually comes within the last couple weeks, September, early October. I've ordered some out to have in our office. We usually put some out in our lobby. Haven't gotten any of the English versions yet. I've gotten the Spanish version. So these should be coming out soon. And we'll talk about the value of this booklet because it's very valuable. It has a lot of good information. It's improved a lot over the years. So use it as a useful guide about Medicare. And one thing I'll tell you about Medicare and the Medicare world in terms of the confusion it causes. I work at the county. I feel pretty lucky that because of that, we have a good benefit package, but our open enrollment at the end of the year gives me two choices on my medical: Regents plan or a Kaiser plan. That's it. There's not any other combinations. It's one or the other. Medicare world, you jump into the Medicare world, there's probably thousands of combinations you could potentially do, hundreds of choices just for the basic coverage. That's why it's so confusing. So those of us in the commercial world who think we're so smart, I've got people retiring from the county who call me for guidance and say, I don't know what choice to make. These are smart people. So don't feel bad if you're overwhelmed and confused about all the products that are out there that have a Medicare label on it, because it can be very confusing. Now, Medicare offices do not exist, okay? You're not gonna drive around and find a Medicare office. You're gonna find Social Security offices. So local Social Security offices act as your Medicare office. Some better than others. Social Security folks are trained mostly in Social Security, a little bit in Medicare. So more often than not, you're gonna be better off calling or going online or visiting what's known as this, having a visit with someone from a state health insurance benefit, SHIVA. They are the Office of Insurance Commissioners, designated folks to guide you on Medicare. So keep that in mind. You're not always maybe gonna get the best answer from talking to Social Security. Now, Medicare has its own phone number there on the bottom, different than Social Security. Those people are trained. But keep in mind, when you call, you're gonna be on hold for a long time. Social Security wait times are maybe 90 minutes, 2 hours. Medicare is usually not that bad, but this time of year, it can easily be that bad. So if you need to call them, make sure your phone is charged, make sure you have the speaker function on, make sure you're right by the phone, because when they pick up, they're gonna give you two or three chances to answer and be ready. If you don't pick up when they're saying hello, they're gonna hang up on you. And they're not gonna call you back. I remember I was on hold with a client for like 2 hours once at her house. They came on the line, hello, hello. She wasn't ready, and so they hung up and they did not call back. So be ready if you need to call them. Has anyone tried calling Social Security, Medicare lately? How long did it take you?
Actually, really fast,
Wow, excellent.
but I did it first thing in the morning.
Okay, great news. That is really good news. I know they're trying to staff it up more. A lot of COVID money funneled in to staff up Social Security, Medicare. So that's really good news, because oftentimes the wait can be very long. Okay, now Medicare. What is Medicare? That's what we're starting with. Medicare. It's your health insurance coverage linked to your lifetime earned income or the income of your spouse, okay? So people have the assumption that any older adult is gonna be eligible for Medicare. That's not true. We have a lot of seniors that are never gonna be Medicare eligible because they never had enough years in actively working, and they were never married to a spouse who's actively working. So it's not unusual, we'll have an 80-year-old person who's never been on Medicare, they could be on Medicaid. So that's a different category of coverage. Most people will qualify at age 65 because most people are going to have worked themselves long enough to qualify or been married to a spouse who worked long enough to qualify. And generally it's a 10-year period because you need 40 credits and you earn, I think, that many credits per year, 4 credits a year, so you need to work 10 years. Other people qualify for Medicare as separate from age by disability. Okay, so you might have somebody my age who's 58, I come down with some disabling illness or injury, and I would qualify for Medicare coverage 24 months after I started my cash disability payment. So if I filed for disability on Social Security because I couldn't work anymore, and I've gotten that cash payment for 24 months, then I'm eligible for Medicare. Now, there's some exceptions to that, like end-stage renal disease, that'll qualify you within a month or two. Typically late-stage AIDS, typically things like ALS, which is Lou Gehrig's disease, is gonna qualify you right away. But normally, you either qualify at age 65 or after a period of time of being on Social Security disability. So if you wonder why that's so difficult, well, number one, it's difficult because it's hard to qualify for Social Security disability. If you've had a friend or family member go through it, it can take months, if not years, to finally qualify. And then you're waiting beyond that for your Medicare. Now, the good news is they backdate your Medicare period to when you first filed your claim if they approve you. But still, this could be a long period where people aren't on Medicare and aren't working anymore. This is where people become impoverished and go bankrupt because they have no income from work and they have no disability income and they have no health care coverage. So that's been 24 months since I've had this job. I don't know if that'll ever change that period. 65 since I've had the job is your Medicare eligibility age, even though the Social Security full retirement age for me is gonna be 67, I can still get Medicare at age 65. And your Medicare card is that red, white, and blue card. It now has a unique identifier. It does not have your Social Security number on it or your spouse's. Remember back in the day, that was a big controversy because people were walking around showing their Social Security card to every doctor and hospital because that was your Medicare number. Now it's a unique identifier. So any questions so far on kind of understanding Medicare? So the booklet, when it comes out, is very valuable because it explains the different parts of Medicare. There's different letter category parts of Medicare. So Part A is covering you when you're in the hospital and when you go to skilled nursing facility care. So you have a broken hip, you go in, you have surgery to replace the hip, and then you rehabilitate in a skilled nursing facility. That all happens on your Part A. That skilled nursing facility benefit pays at 100%, as does your hospital, but there's a deductible of $1,600. So we always remind people, if you go into the hospital for any kind of admitted reason on your Medicare, it'll be covered at 100%, but you're gonna have that $1,600 they're going to bill you. So we remind people, talk to the hospital financial office to do an application to get that $1,600 paid under financial aid. Those programs are very generous. I'm guessing a lot of seniors in this room would qualify for hospital financial aid, but you aren't gonna get it unless you apply for it. It's a front page, back page application. You just have to send proof of income in, and most of the time you're gonna be approved for all of that to go away or a good chunk of it. Anyone in the room ever applied hospital financial aid? So what was the results?
100%.
100%, great. And oftentimes they'll include the network of doctors you're seeing. So if you get approved for multi-care, that means multi-care doctors, so your co-pays go away. Did they approve you for like a year or 6 months?
Well, when I first did it, it was only a 6-month and I just had to do it again recently and it was a year.
Great, wonderful. How about you?
12 months.
Wonderful, great. So this is one of the best kept secrets out there in terms of limiting medical costs on Medicare for seniors, because most seniors get that bill and they think, oh my gosh, $1,600, I'm going to the hospital again. We don't want that to happen. We want them to get the care they need. So if you got a friend or family member, this is where we need you guys being the force multipliers in the population to remind friends and family to apply. Easy application, but big payoff for doing it. Okay, Medicare B, that covers anything you're doing in the community, doctor visits, lab works, diagnostic testing, also covers some medications and medical supplies. This gets confusing to people because there's A, there's B, there's D. There's new things coming on for Medicare B though, acupuncture being one. That's covered now for 12 annual visits to treat specifically chronic lower back pain. So this is something new the last couple of years. Chiropractic is covered for some things now. Now, Medicare B typically has a premium. This last year, it's been $164.90 a month. I don't know what it'll be yet in 24. It also has a deductible. This year, it's been $226. So again, think of that hospital financial aid when you're thinking of these costs. And that Part B can be delayed if you're actively working. So if I keep working past age 65 because I have county coverage, I don't have to start paying that premium. I would take the A because there is no premium, but I would forego my B and delay it without penalty as long as I'm actively working. Yes?
When we got caught on, you have to always be aware of, is if your spouse goes to laid off and goes on COBRA,
Yes.
you have to get the
That's right. Thanks for bringing that up. COBRA is not considered active work. And most people think it is because it's attached to work, but it's not considered active work. Nor is going out of the country exempt you from paying the premium. Now, if you move to Costa Rica and you're loving life there and you're thinking, I don't need my Medicare anymore because I'm in Costa Rica and I can't use it, you come back to the US and they're gonna tell you, tough luck, you've been out of the country, you didn't pay your premiums, and now you're gonna be locked out from your B. They're gonna lock you out until January 1, and then you can apply for the following month with a penalty. You're penalized 10% a year on the premium for each year you didn't enroll. So did you guys incur a penalty?
No, because we learned soon enough that we're still in the window.
Wonderful.
To apply.
Great, great. So you can,
Nobody told us.
well, this is the tricky thing, yeah, and I'll be honest with you, when we used to have the Medicare trainings up in Seattle, and this isn't a knock on them, it's a very confusing, complex system. Sometimes you'd ask the Medicare, the guy at the meeting on Tuesday a question, you could ask the next Medicare, the guy a question on Wednesday and get a different answer. So you really need to dig into the details. Yeah, it's tough, it's tough. And we've had people leave the country and people that seem pretty competent call our office and say, I know they told me when I left the country I could quit paying my B and nothing bad would happen to me when I came back. Not true. You've got to keep paying it if you leave the country, if you want to have it when you return to the US, okay? So keep that in mind. The other thing you want to keep in mind, there's a separate number to call when you finish work and let them know you're not working anymore. Because oftentimes, if they've got it in their system that you've got other work, especially if you work past age 65, those claims will kick back because they're going to say to me, Matt, you're on Pierce County coverage, you can't claim Medicare, but I'm not working anymore. Well, you didn't tell us that, okay? So there's some complexities there, some trapdoors. Okay, what is Medicare Part C? So this is where we get into open enrollment coming October 15th. Open enrollment is relevant to changes with regards to your C Advantage plans and your D prescription coverage. So we talked about A and B. A and B, once you got it, okay? It's not going to change year to year, but how it's administered, how it's covered can change. So a Medicare Advantage plan offers modified A, B, and D benefits under the management of contracted insurance providers. Now they can impose additional premium deductible copay costs. They put you in a network of physicians, but it's guaranteed issue, even with end-stage renal disease. And by that, I mean this year on October 15th, if you've been on a United Healthcare Advantage plan, you want to switch to Humana, it's guaranteed issue. They can't say no because you're too old. They can't say no because you're too sick, okay? So year to year, that's your opportunity to make changes. Now, when I started this job, there was one kind of Advantage plan. It was called Secure Horizons, and that was pretty much it. Now there's, I think, 71 to choose from. This is why it gets so confusing. And they all know who you are, so they're gonna send stuff to your mailbox. And some of it might be very deceptive looking, might say Medicare Bulletin, important Medicare information. They're just selling you a product, okay? They're selling you their product and they don't know, they don't care what your health condition is. They just want you to buy their product, okay? So keep that in mind when you get the marketing material because it can be very deceptive in making you think you have to go for that. Plus, with some of these additional benefits, there's some good deals, okay? So I think Humana offers you like a $100 purchasing card, $100 extra a month you can use to buy stuff at a grocery store, okay? So sometimes they'll advertise on the TV, you're missing out on $1,200 of Medicare benefits. You're missing out. And clients will call us and say, oh my God, I'm missing out. And we'll say, no, you're not being deprived of anything. They're just telling you, if you buy their, you're gonna get an additional $1,200 you're not getting now. So this is where the deceptions sometimes come in. Medicare E, that's your prescription drug coverage. That's also guaranteed issue. It can be delayed if you're actively working on the Part B, similar to that. And this is where it gets even more complex because you brought up COBRA. COBRA is creditable coverage for Part D. So you don't get penalized on D, but you would on B. So now we're in the world of confusion, right? Is everybody already confused? And we're only, what, 20 minutes into the talk, so there you go. This is where it gets confused. Medicare does not pay for long-term care, okay? You can have all of these different benefits and packages, none of them pay for long-term care. And by that I mean care in an assisted living facility, caregivers coming into your home to take care of you, care in an adult family home, long-term care in a skilled nursing facility. None of it is covered by Medicare. Medicare A only pays for skilled nursing facility, time-limited care, only during the period you're rehabilitating, okay? So let me give you my mom as an example. She fell multiple times at home, finally fell, had a terrible concussion, had a brain bleed. She went into hospital for a few days, they stabilized her, brought her to skilled nursing facility. She was rehabilitating, they were giving her puzzles and occupational therapy, physical therapy. Within about 3 weeks, she got about as good as she was gonna get. Now, she wasn't well when she went into the hospital because she was suffering dementia, mobility issues, falling. So after 20 days, they basically said, okay, your mom's as good as she's gonna get. She wasn't well enough to return home. And at the time, we were fortunate that we had the assets to pay $10,000 a month to keep her there in a private room. But just because she couldn't go home, Medicare was gonna pay for her to stay there. And if she had stopped rehabilitating within a week, it would have been the same story. They would have said, her benefit's done, she's just here for long-term care. And by long-term care, it means eating, dressing, grooming, medication management, whatever she would need, but it doesn't rehabilitate her. So she wasn't getting any active rehabilitation past that 20-day point, okay? So this trips up a lot of people because they think, well, mom was covered in the skilled nursing facility. We had a home health person come at home and take care of her for a few weeks. What do you mean Medicare doesn't have long-term care? It does not have long-term care, okay? It's very time limited and specific to rehabilitation, okay? Any questions on that? Okay. And this is where it gets confusing because this isn't a political comment, it's an observation on language. A lot of politicians talk about Medicare for all. But when you hear them describe what they're offering, it's not Medicare. It's more likely going to be Medicaid, okay? Because they're describing a program where the government's paying all of your out-of-pocket costs for everything you need. We've just talked about Medicare has costs, right? So Medicare for all is not Medicare as we understand it. It'd be a different thing. I'm not saying that's a good or bad thing, but I wish the language was a little more clear. Because again, people go from the commercial world into the Medicare world and they're like, wait a minute, there's a gigantic deductible, $1,600 deductible? What the hell's up with that, you know? Because I don't have a deductible that big as a commercial worker at the county. If I go into the hospital, I think my out-of-pocket's like $100. But you go into the Medicare world, it's $1,600. That's a pretty big chunk of change, so. Okay, so when you go into that handbook, there's a lot of good information describing what we're talking about, Medicare, Medicare Advantage, prescription Part D. All of the covered services are listed, including the preventive services. And remember, age and medical history are key there. So you've got to make sure your doctors know all of your illnesses, all of your injuries, close siblings' illnesses and injuries, parents' illnesses and injuries, because those preventive services are going to be based on your health profile. So you can't just march in there and say, hey, I think I want a colonoscopy every 5 years instead of every 10. They're going to say, what, are you nuts? But if you've had a brother with colon cancer, they may very well say yes. Or if you've had a previous episode of cancer, they may very well say yes. You need to be on a more aggressive schedule, okay? There's a lot of preventive services out there. One of the good news things is all of the recommended vaccines now are considered preventive that the CDC has listed as such for older adults. So shingles didn't used to be covered at 100%, it's covered at 100%. That vaccine, RSV that's circulating, that's covered at 100%.
Oh gosh. Did I get that?
Flu, of course, that's covered at 100%. Pneumonia is covered at 100%. So we want to make sure you folks that have thought in the past those things are going to have an out-of-pocket cost, they don't any longer, all those recommended vaccines. So this is the first year coming up in October, you could do flu, you could do an updated COVID booster, and you could do the RSV vaccine. That's something brand new, so.
Are those something you can get either at your doctor's office or at, one of these places offers free? Does it matter?
No, it should not matter. They should all be billable. Now, it gets confusing because certain of them are billable under B, certain of them are billable under D. But they should know which one they're supposed to bill to, so. Typically, the local pharmacies, I think, are gonna have all that available here in October. That's what they're telling us. The new COVID booster that's coming out is to address these new variants that have been circulating. And the guideline I checked last night is if you had a summertime booster, you can get this new updated booster 2 months after whenever you got that booster. So it's just a 2-month spread there. And they are recommending it basically for everybody, even little kids, to get this updated booster. So keep that in mind if you're gonna go forward with that. Any questions on that? Okay. So when we head into open enrollment, I'm just gonna keep talking. When we head into open enrollment, the things to think about are October 15th is when you can first start deciding and making changes for your coverage going into 2024. You certainly don't have to make any changes if you're happy with your coverage right now. But in addition to the Medicare and You booklet, you should be getting a renewal booklet from your current plan, whether that's an Advantage plan or a Part D plan. And that renewal booklet is going to tell you what changes have happened with premiums, deductibles, and copays in the new year. Now, in years past, they would also send you a pretty significant network directory of their doctors. They would send you a pretty significant pharmaceutical directory. I don't think they're doing that anymore. They're probably going to refer you to something online. So what I tell people is talk to your doctors around this time of year to make sure the plan you're in is a plan they're going to continue to be in, because I wouldn't rely on their directory to be current, up to date with what your doctor is doing. Years ago, when these plans first came out from year to year, we would see a lot of disputes. A plan would say Franciscan's not playing with us anymore, Multicare is not playing with us. That hasn't happened for years. So it seems like the plans are pretty well dialed in with doctors covering both networks. But you always want to talk to your doctor first to make sure that's true, because they're going to be the ones that know what plans they're taking. And remember, when we're talking these plans, we're talking about dozens and dozens of different plans. So it's not just a few, there's a lot. So this is a burden on the doctor's offices as well. And each plan typically has its own requirements to getting things approved, meaning the doctor has to intervene and justify why something's happening. So we'll talk about a little bit more about that as well. So we think we're live again?
Yeah, we never stop streaming.
Oh, great.
Question.
Yes.
So I'm gonna turn 65 next year, and
Okay.
so is the open enrollment for me turning 65 next year only between October and December of this year?
So great question. So what happens when you turn 65 and you're outside of the open enrollment period? You have what's known as an initial enrollment period, an IEP, which typically goes, I believe, 2 months prior to your 65th birthday, and I think 2 or 3 months after. So that's your period where you can say yes or no, you want to be on Medicare A, B, and whatever Advantage or D plan you want to be on in that window. And that'll happen outside of open enrollment, depending upon when your birthday lands.
Okay.
And then if it's earlier in the year, then you're gonna have another open enrollment period in the fall. So you could potentially be locking something in then and then making a change later that year. But year to year, it always happens October 15th to December 7th. And during that period, if you're actively working, then you can decide, do you want to have the Part A? Most people add A because it doesn't cost them anything. Most people would forego the B and the D and the C because you have coverage through work. So is that your situation? You're gonna have coverage through work, or are you not working? Yeah.
I'm retired.
Okay, great. So yeah, so you definitely want to jump on and take advantage of your Medicare benefits. Yes.
We have a question online. Are Apple Health Medicare plans different by state or county, or by county?
So the question is on Apple Health Medicare Connect plans. I can have a slide on that. Let's see. Apple Health Medicare Connect plan. Those are specific county to county. So the question came on about Apple Health Medicare Connect plans. These used to be called special needs plans. These are plans that offer enhanced benefits to people in certain institutional settings, certain illness categories, and certain Medicare Medicaid combination categories. These plans offer not only zero premiums, deductibles, and co-pays, but they also offer enhanced dental, vision, and hearing. So when we're in the Advantage Plan world, and we'll talk about that, those are county to county in Washington State. So you could have a United Healthcare plan in Pierce County that's not available in Benton County. It just depends on how they market. And then it's gonna be different even again if you move out of state. So this is why Medicare requires you to declare your residence when you're adding on to these plans, because it can vary. So if you can't use United Healthcare Pierce County Advantage Plan coverage if you're in a different county, because the doctors aren't gonna recognize it. So they do follow you on that. And this comes up for people that are snowbirds, because Arizona's plans are different than Washington's plans. You can't have both. You have to declare what's your regular residence. That's where your Medicare coverage is gonna originate from. Now, if you stay with original Medicare and never add an Advantage plan, then you move across the country freely, and any doctor you can see then, because they're gonna take your Medicare coverage. But when you join the Advantage plan world, you're gonna be out of network when you move out of your county or out of your state. Okay, so let me give you the example of like Kaiser, which I have, and which my mother-in-law, the father-in-law had. That was specific to Pierce County. So if they were to have moved to King County, Benton County, Kamiakin County, wherever, they would have had to have a new enrollment period based on their moving. And if they had moved to California or Arizona, they again would have had a new enrollment period to make a complete change to a local coverage there. So this is where it gets more confusing again, because Kaiser is my best example. You join Kaiser in an Advantage plan, you're gonna see the Kaiser network doctors. And for the most part, those are gonna be Kaiser employed doctors. So if you live up here and you say, well, I wanna go to Dr. Jones down at the multi-care clinic, Kaiser's not gonna approve that. You're gonna need to go closer into town where Kaiser has approved doctors, okay? So that's where the Advantage plan networks can trip people up. Yes?
So you were talking snowbirds, but what if you're just like on vacation for 2 weeks someplace else, you might not be able to access Medicare?
So great question. So typically, if you have an Advantage plan out of your area, they're going to cover specific urgent or emergent care needs. They're not gonna cover you just because you wanna go see a favorite doctor that your neighbor recommended. So that's why I always advise people in the Medicare world, check on those Advantage plans, what the benefit is for out of area urgent or emergent care that you might need when you're vacationing. If you go overseas, some of the Advantage plans have out of country coverage, many don't. So think about travel insurance in those situations. Yes.
This may apply to that, but a question online was, so do people with 2 residences have to constantly re-enroll in 2 different states each year?
So if you did have a residence in another state that you spend time at, you're going to have to declare one or the other as your residence. And you can change it year to year freely, but in doing so, you're gonna be limited by the coverage it's providing you in that local area. So we recommend that you talk to your plan and find out, do they have a sister plan in that other state? So you can continue to access a doctor's network with that coverage. That's what we usually recommend. Normally, there's some that have coverage in other states, some extended coverage. Many of them don't have any out-of-network coverage though. So that means, again, you're gonna be in an urgent or emergent situation where you'll be seen, or you're gonna be having to telehealth with your doctor here in Washington while you're living in Arizona. And he's gonna be happy sending orders to your pharmacy down there, whatever the case might be. So it does get a little confusing for those other state situations. Okay, and then other things about Medicare, we talked about acupuncture, we talked about the vaccines all being covered now, that's great news. Chiropractic's covered. Basic Medicare still does not cover dental, hearing, and vision, okay? It doesn't have any benefits for those. Unless you have a disease of the eye or the mouth, like cancer of the mouth, or you have a cataract or glaucoma treatment, but routine dental, vision, and hearing is not covered, which is one reason that people do end up joining Advantage plans, because they do offer dental, vision, and hearing benefits. So when you're starting to think about open enrollment, you want to think about what's your current plan? Is it an Advantage plan or just a D plan? And then you want to be mindful of, if you want to make a change for January 1, what things to think about. you're gonna wanna think about things like, eligibility for, insulin coverage. All of the insulins are now covered at a maximum of $35 a month, okay? That's really good news. On the Advantage plans, you wanna think about things like provider networks. Is your doctor in the network? Making sure your specialists are in the network, and whether they offer any enhanced dental, vision, or hearing benefits. So this is where people really join in on these Medicare Advantage plans. Right now, there's 52% of all Medicare beneficiaries are in an Advantage plan. And oftentimes, the reason is they have lower costs on the percentages. They typically have a set fee for copays. Plus, they offer things like dental, vision, and hearing. Some offer health club memberships, some offer medical transportation, some of them offer a grocery purchasing card and things like that. So a lot of people are joining these Advantage plans because they offer these additional benefits that regular Medicare does not offer. So this tipping point came pretty quickly, actually, because it's basically, I think, been 17 years since we fully expanded these Advantage plans. So already we're over the 50% threshold on Advantage plans. So people often ask me about Advantage plans, do you think they're gonna stick around? Well, they're sticking around. So I think over time, Original Medicare is gonna seem like a less and less attractive choice for people, and more people are gonna go into an Advantage plan. That's just an observation, not a recommendation, because you do get these other enhanced benefits. So if you ever have the chance to advocate for a federal legislation, talk to a congressperson or your state's or a senator, Murray, Cantwell, one of our congresspeople, you might wanna ask them, when is dental, vision, and hearing gonna be attached to Original Medicare? Because that other 48% of people are really missing out, and they really are missing out in that there's another choice available to them, but a lot of people don't wanna go into an Advantage plan. So that's why a lot of people join it though, because those enhanced benefits are there. So any questions on that? So this is old information. So again, I wouldn't put too much stock in the numbers there, but with these Apple Health Medicare Connect plans, these are for lower income people, Medicare, Medicaid people, some institutionalized people. We talked about those Medicare savings programs. Humana offers this enhanced coverage for anyone that's on a Medicare savings program. So more and more, these Advantage plans are picking up a population of people who are very much in need and giving them these additional benefits. Now, why do they do it? Why would an Advantage plan give all these extra benefits to people? Well, they do it because Medicare pays them for each person they enroll. And then they pay them year after year for having that person enrolled. It could be anywhere from several $100s per person they enroll to several $1,000s. So the Advantage plans, that's why they're companies like Humana, United Healthcare, Aetna. A lot of these are like financial companies, right? You're like, wow, how are they in the Medicare business? Well, they're in the business because they're getting a lot of money to enroll people, to take these people off of Medicare's authorization process. So when you're on a Humana or a United plan, they're controlling your benefit. The billings go to them. The doctor's network is approved by them. They approve procedures and things you might need. So Medicare's out of it at that point. So when you're getting your notice of what's been paid, what the claim was covered at, that's coming from Humana. It's not coming from Medicare anymore, okay? So people often ask me, oh, I've lost my Medicare, I'm not on it anymore. You're on it, but Advantage wraps around it, okay? It's like a wrap around your benefit, and you can dispense with that wrap and go back to Original Medicare, but a lot of people are really happy with the wrap because it gives them all these extras. But there's an incentive for the Advantage plans to do this, okay? They're all in the market competing for you to join their plan. And there's brokers out there who would love to talk with you about changing to a plan that they're marketing because they're gonna get a piece of that action as well. So I'm not criticizing that, again, an observation that people need to know. This is all marketing, selling you products and services, and someone on the back end's making money off the choice you make, okay? So that's why you have to think of what the best choice for you yourself in terms of your healthcare situation. Okay, we talked a little bit about Apple Health Medicare Connect, and that'll connect kind of with Medicaid when we talk to it. Thinking about the structure, you always want to think of premiums, deductibles, co-pays, what your out-of-pocket cost is going to be for medications and things like that. The medication coverage is gonna get better. In 2023, they've capped, actually 2024, if you have high prescription costs, you're gonna get full coverage when you hit a certain threshold. And I think it's in 2025, might be 2026. The most you'll pay out of pocket in a full year is $2,000 for your prescriptions. So this is a big change because there's never been a financial cap on how much you could pay out of pocket for your prescriptions. But either in 25 or 26, the most you'll pay is $2,000. So if you're taking a lot of expensive brand name treatment medications, as soon as you've paid $2,000 out of pocket, whether that's in February, March, July, August, you're gonna get covered at 100% then. This is a big, big change, a positive one on the Medicare side. But remember, they can impose restrictions. They can tell you you have to take a generic. They can tell you you're limited on quantity. They can tell you you need other steps of medications before you get that brand name medication, and they can require your doctor to authorize medication. So your pharmacy should know all that and should be telling you that and telling your doctor if something extra needs to be done to get a prescription you need authorized, okay? These are all about cost control, and that's why that information is there. So again, always want to think about premium deductible co-pays, preferred pharmacies, where the discounts are, okay? Are all your medications covered by your plan year to year? Making sure the insulin costs are capped at $35. A lot of them are moving into this preferred or network pharmacy thing. You're gonna save a few bucks if you go preferred, probably save even more if you go mail order. And then with the Advantage plans, the other layer there is, are your doctors in your plan network? Again, most of them are in all the networks now, but again, you wanna make sure you talk to your doctor and you wanna double check if there's vision, dental, and hearing coverage as well, because a lot of them do offer that now. This is Medicare supplement information. We're not gonna dig deep into this because it's not really relevant to open enrollment. But a Medicare supplement's different than an Advantage coverage in that it pays the remaining cost after original Medicare pays. This is an insurance product. Not everybody who's offered an Advantage plan would be eligible for a supplement plan. They can impose age restrictions on the premium. They can impose a health screening. So I'm guessing most of the people in this room aren't on one of these, but you could get on one of these. Now, again, you only have original Medicare when you add a supplement. And so my parents had one. It cost them about $300 a month, each of them, to have this coverage. But when my mom got sick, when my dad got sick, it pretty much covered everything original Medicare did. If you have an Advantage plan, you can't get a supplement, okay? They're two different things. So don't get confused by the terms. If you hear supplement, it's adding to original Medicare's coverage, but it's still original Medicare. If you're going Advantage, it's that wrap. The Advantage plan is wrapping your benefits and taking control of it. So what do you do if you want to change? You don't have to do anything if you want to stay with what you've got. You'll get the renewal booklet. You want to look in there, but if you want to make a change, you've chosen a different plan, you can call Medicare. You can go on their website and do it. You can call the Sheba folks at State Health Insurance Benefits Advisors. Their local office is South Sound Outreach. If you make a change, your current plan will get knocked out for the new year. So January 1, that new plan takes over, your old plan gets knocked out. But if you're happy with what you got, you can stick with it. And if you're happy with what you got, that's fine. Just ignore all the marketing. If you see something different in there that you're not happy with, you can think about making a change. You can make a change every year. The only thing I'll say on Advantage plans is that if there's a benefit on there, max it out. If they're giving you $200 for eyeglasses, get those eyeglasses. Next year, get another set of eyeglasses. If you need some dental work done, get it done this year, use it up again next year. If there's hearing aids, you can get them, okay? If there's a health club membership you can use, get that. Max out those benefits. You don't want to get to the end of the year and say, geez, I never used these benefits. Max them out, use them. And then I gave information on the Medicare savings programs, how those work in paying the B deductible. There's also information on the sheet about extra help and how that provides some additional prescription coverage. Similar eligibility on those. We're blessed right now, again, the state of Washington has no asset or limit test for Medicare savings program. It's very unusual nationwide. And we'll talk a little bit about that more with Medicaid. And that's on the information sheet there in regards to the income. 1640, that includes all income, social security, pensions, things like that. Married couple, 2219. No resource limit though. So anyone listening online, please call us about more information on this, because there's lots more people who could get on these programs that don't even know they're out there. So you definitely want to get on these programs. It's gonna save you a lot of money. Extra help, we'll skip that. Always beware of anyone calling you about Medicare, no matter what, because they're scammers, okay? Even if they're legitimate companies calling you, they're breaking the rules, because they can't call you, just cold call you. They can only call you if you inquire with them. So anybody calling you about Medicare, I'll say again, it's a scam or it's improper marketing, okay? And they can spoof that number on your caller ID. It could say Medicare, it could say Social Security, it could say federal government. Don't trust it, okay? If they're marketing you anything with regards to healthcare coverage, please hang up. And like I talked about, Walk Cares, you can't buy into that, but you're gonna get calls about it, because we're hearing that people are already getting called about that. Again, with COVID, the new booster covered at 100%. They just announced yesterday that the home testing kits, they're gonna reactivate that federal government testing kit line where you can call or go online and order testing kits. I have 4 packs of testing kits here if you need them. Remember, we're in the world right now where you're gonna home test. If you're positive, you're gonna call your doctor and say, I'm positive. If you're a senior or immune compromised, you're gonna say, I want Paxlovid. Paxlovid's the oral medication you can take to minimize your symptoms of COVID. So my wife took it, she positive tested at home, we called the doctor, the next day they sent the order out. I went to the pharmacy, she took 3 medication pills in the morning, 3 at night for 5 days, cleared her of the virus, resolved her fever. By the 6th day, she tested negative. It works, it gives you a terrible metallic taste in your mouth as one of the side effects, but it works, it's worked for my wife. So no more testing at home, positive, worrying. Talk to your doctor about Paxlovid. There may be others out there like it, but that's one that I know works, okay? So think about that if you test positive. And you test at home. So if you're not feeling well, test at home and then call your doctor, okay? Walk Cares, we talked about that, what it is. That's for active workers. You want to ignore that if you're retired or disabled. It's not going to help you, so don't worry about it. And again, don't fall prey to scams on the Walk Cares. Last page is our resource information. This kind of concludes our Medicare portion of the presentation. Then we'll talk about Medicaid. If anyone has questions, these are great resources. Our office, the State Office of Insurance Commissioner, Medicare, SHIBA, the State Health Insurance Benefits Advisors, or Social Security. No one's gonna have information until after October 1 about new plans available for 24. And again, open enrollment in terms of when you can actively think about changing starts October 15th and runs until December 7th, okay? So that finishes the Medicare portion. We'll take a couple minutes break and jump into Medicaid. Any final questions on Medicare? Yes.
So I have Regents
Okay.
insurance and I really like my doctor and
Great.
my insurance plan. Can I keep Regents and also have Medicaid?
Yes, Regents is a participating Medicare Advantage provider. So you're gonna definitely have that choice where you're basically gonna be moving the coverage, but you'll still have the same provider network. So Kaiser's another one that participates in the Advantage world. So you shouldn't have any problem of choosing a Regents covered Medicare Advantage plan. I couldn't tell you what the premiums and things would be. More and more they're offering 0 premiums because they're competing on that level. So you might even be able to find a 0 premium Advantage plan.
Not in regions,
What's that?
not in regions.
Oh, really?
There's a difference between PPO and HMO,
Okay.
but there's no 0.
There's no 0 cost, okay, so there are, thank you for that. So right now, you'd have to pay something to have that Advantage coverage, but it's probably going to be very close to your commercial coverage. You're just gonna wanna check vision, dental, hearing, because you probably have that in your work coverage. Wanna make sure
That's
the
a
Advantage,
rider.
does it have some?
Vision and hearing is a rider.
Okay, so you can add it, it sounds.
I just want to keep my doctor.
Yeah, so you should be good with that, yeah, you should be good, you shouldn't have any trouble with that one. Now, again, I can't predict for next year, but Regents has always been a player in the market, so I'd be surprised if they weren't.
It's more like if the doctors want to keep you when you go to Medicare,
Yeah.
because not all doctors do.
Yeah.
Yeah, that would be a discussion you wanna have, you definitely wanna have with them, just let them know you'll be changing far in advance. And, It's very tough. This is why we're always reminding our folks, build that relationship with your doctor, maintain it, and I know it's tough, a lot of doctors retired after COVID, it became a lot more difficult to get seen, but you gotta build that relationship with your doctor, because when it's time to get orders, you need to get orders when you need them from the doctor. If they don't know you, they haven't met you, you've missed appointments, they're not gonna be willing to write orders for you. It's getting tougher and tougher to have cooperative relationships with doctors, because they're overwhelmed, there's not enough of them around, our population's aging. So the sooner you build that relationship, the better, and you really need to be seen. If they say they're willing to do the telehealth, that's great, but you gotta have some sort of face-to-face contact with them, because if you don't, you're gonna run into trouble when you do need orders. And a lot of the things we talked about, you need orders for medications, skilled nursing facility coverage, vision, dental, hearing, even if it's not a covered benefit, you're often gonna need an order for it. I think right now, even to get a disabled parking permit, they've added another layer where you need a doctor's order written to get that parking permit. People are nodding their heads, right? Because there was so much fraud, you know, everybody and his brother had a disabled parking permit, they're perfectly healthy, so they added this extra layer where you need that order. So something as simple like that, now they want doctor's orders. So it's getting harder and harder to get things done healthcare wise, benefit wise, unless you have that strong doctor relationship.
Well, and additionally, sorry, I go to Sound Family Medicine.
Yeah.
It's like literally 10 minutes from my house.
Exactly.
So I wanna stay in the area and not have to change doctors and now have to go to Puyallup or.
Exactly, so that, again, this would be a discussion that you'd wanna tell them, say, hey, I'm moving into that world, just wanting to make sure I can stay established here as a patient. I'm sure they'll carry you over. Might be a little tricky if you're starting brand new with a relationship, but I'm sure that you want to carry you over.
Thank
But
you.
Worth talking about. Yes,
Do you have any idea how Medicare compensates physicians for telehealth versus in office?
no, that's a good
Any
question, I'll
incentive?
have to research that. I know they,
Incentive for-
it became kind of a mandatory practice during COVID, it wasn't so much prior to that. And in fact, most doctors' practices didn't want to do it, but now I think it's pretty common they do it. I even went to urgent care a few months ago at Kaiser, and they actually had a doctor on the screen. I don't know where he was, but he was on a laptop attached to a pole, and he was talking to me while the nurse sat there. So they're doing a lot of it even for urgent care type things. So normally Medicare's reimbursements are pretty low for doctor services anyway, especially for primary care visits. So I'm guessing it must be commensurate with face-to-face or close to it, else they wouldn't still be doing it. But if you ever look at your explanation of benefits, the billable amount, which is what's paid, is pretty meager, actually. So that's why Medicare is kind of considered to be a lesser payer than commercial insurance, yes.
Is that accurate now? Yes?
Yes.
Okay.
So basically, when you look at that world, commercial insurance pays the most, and then Medicare pays less than that, and then Medicaid, which we'll talk about, pays even less than that. So that's why we're talking about commercial insurance, your choice of doctor is usually pretty wide ranging, because they're getting paid the most there. Then you jump into the Medicare world, they're getting paid less than that, plus the cases are more complex. You get into the Medicaid world, they're paid even less than that. So that's why jumping into the Medicaid world from Medicare, even you see a disparity in care outcomes, because fewer doctors will take Medicaid. So right now, Pierce County's still pretty good on Medicare taking doctors. The networks are still pretty strong. Let's keep our fingers crossed it stays that way. Medicaid's a little bit different, so. Okay, so jumping into the Medicaid world. So we're gonna talk about Medicaid programs, understanding them for our senior disabled clients, friends and family that might be here. When we talk about Medicaid eligibility, if I use the term resource or asset, those are interchangeable. Those could be things like real estate, it could be anything in a bank account, it could be stocks, bonds, mutual funds, life insurance, and burial plans, motor vehicles. All of those things are considered resources. Sometimes you'll hear them considered as assets. So when we talked about the Medicare world, you age into Medicare or you disable into Medicare, there's no asset test, okay? You could be a millionaire, you could be living homeless and no income at all if you qualify on Medicare. If there's no asset test. Medicaid's a different world where there's asset tests, okay? And there's some income tests as well. So the terms are definitely not interchangeable, okay? Medicare is a federal benefit, Medicaid's a state federal benefit, so each state can manage it a little bit differently.
Can you repeat that?
Yes, so Medicare is a federal benefit. The federal government controls Medicare. Medicaid's a combination federal and state benefit. So state by state, it can vary dramatically because each state administers it through their own local social services administration office. A little bit different. So we're gonna talk about eligibility, client obligations on Medicaid programs. There's a lot of complexity that goes with it, including functional need. Just because you're on Medicaid doesn't mean you're gonna be eligible for all Medicaid programs. We'll talk about that a little bit. Year to year, things can change on Medicaid. Income asset eligibility can change. California, apparently in the year 2025 is going to have no asset or resource limit on Medicaid. Don't know how that's gonna work. I really don't. Right now, if you're on Medicaid, trying to access services, it's very difficult, there are very limited choices. I can't imagine adding the whole population of California to the Medicaid program, because that's basically what they're saying. I don't know what their income limits look like, but you know, we all know people on Social Security, you might be one of them that has a limited amount that's coming in, but has a pretty good chunk of change in the bank, right? So right now, in the state of Washington, that's not the case. There are asset limits, and we'll talk about that a little bit. It's not transferable state to state. So we talked about Medicare. It's transferable on the original side, state to state where you move. We talked about where you live and advantage plans, but you don't lose the benefit. If you live in Washington and you're on Medicare, and you move to Oklahoma, you're still on Medicare. Medicaid, it's different. You need to terminate your state programs because you can't have a Medicaid Washington program in Oklahoma. And then it's up to you to walk into the Oklahoma Medicaid office and get started. It doesn't follow you. So it's state specific. We're gonna look at programs for single and married adults age 19 and over. We're not looking at children's programs or temporary aid for needed families. We're talking about single or married adults. Again, number 3, the two terms do get conflated. So don't believe most of what you read. They interchange them. The journalists don't understand what they're writing about. Someone told me years ago, I think a professor in college who took a journalism course, and he said, you'll understand how poorly educated journalists are when they're writing about something you're an expert on. And this is the truth. Boy, when I read these things, I'm tearing my hair out because I'm like, my God, this is completely wrong what you're writing, and you've clearly done no research on it. As a reminder, Medicare's healthcare coverage, red, white, and blue, for clients age 65 or on disability after a period of time. Medicare does not pay for long-term care. Medicaid across different types of programs is always linked to income and resources, always, in the state of Washington for now. Some programs also require you to have a functional need, meaning that just because you want a certain level of services, you're not gonna get it unless you screened in for a functional need for it, okay? But Medicaid does pay for long-term care. Medicare does not, Medicaid does. You're required when you apply for Medicaid to provide the state of Washington Department of Social Health Services consent to search your financial records going back 5 years. There's a look back period for 5 years from the time of your application. And that's used to determine whether they might disqualify you for eligibility. It's a look back period, meaning that if you transferred your house to your son 3 years ago, they're gonna find that. And they will find it, believe me, they will find it. Because we have clients who say, oh no, everything's fine, I did nothing in the last 5 years. We say, okay, we're gonna help you do this application based on your reporting. And then they get a letter from DSHS that says, oh, what about that house you sent to your son who lives in Nebraska? You're like, oh, that's right, I forgot about that. Did they forget about it? Did they not report it? They're gonna find it. So we tell people, you better report it because they're gonna find it, okay? When they find it, they're gonna say, what's the status of that? Is that permanent? Are you getting that house back? And if you say, oh yeah, my son already sold the house, then they're gonna say, okay, that house, what it sold at, there's a formula where they're gonna say, you sold an asset that was given, that your son took from you or you gave to him, and now you're not gonna be eligible for Medicaid for a period of time. That could be days, weeks, it could be months. We've seen it happen to clients.
People online, sorry to interrupt.
Okay.
They're not seeing
Not seeing what
Oh,
you're seeing.
People online are only seeing the title slide, they haven't seen the rest of the slides
Oh,
yet.
no.
that happened once at home, but it was a connectivity issue, I think, so. So that's one to think about is this look back period. It used to be a 3-year look back period, and now it's a 5-year look back period. And this trips a lot of people up. So again, this is where I worry about scammers. Sometimes you'll see folks who are advertising on telephone poles, sell me your house, whatever the case might be. So scammers sometimes are looking to do life estates and property transfers for folks. And you can't just kind of think the Medicaid system. It's even more complex than the Medicare system. So we always encourage people, if you want to do some long-term care planning, to talk to an elder law attorney who knows about this stuff, because you can't just willy-nilly start dispensing of assets. Because the first thing, when I tell people about this 5-year look back period, the first thing they say is, oh, I was planning to transfer my house to my son anyway. Oh, I'll just start gifting over money. It's like, whoa. That's a great idea, but this is a 5-year period that they're gonna look at. So they're gonna find those transfers. And sometimes they're gonna say, you need to get that house back to qualify. You're gonna need to get that money back and spend it down. It can get pretty nasty, okay? So I would strongly advise folks, if they're doing long-term care planning, as anybody should, to talk to an elder law attorney before you get into these issues with Medicaid. And the reason it becomes an issue is because care is expensive. It's very, very expensive. My parents, we had 2 8-hour shifts going in, one Friday night, one Tuesday night, and then we had family members on the other nights. Just those 8-hour shifts were running us, I think, $275 just for the basics each time somebody came for 8 hours. When my mom went into the care facility, it was $10,000 a month for a single room. I called that same facility. That was back in 19. That's up to, I think, $14,000 a month. Adult family home could easily run you $10,000 a month. Assisted living could easily be $8,000 a month, especially if you needed secure memory care. So even with some money in the bank, it could get spent down pretty quickly, okay? The other provision that many Medicaid programs have is what is known as an estate recovery provision. Because your home is exempt, as is the belongings in your home, as are your car, $2,000 you can have for a single person. So by estate recovery, what I mean is if you're 55 and over and you go on Medicaid services and it's paying for your home care, paying for your care in a facility, when your estate is settled, if you still have that home in your estate, they're gonna notify your executor and say, hey, your mom clocked in $200,000 of Medicaid services. You as the executor have to put us first in line for that money to be paid back. So the Office of Financial Recovery keeps track of this, okay? There has been talk for years about getting rid of this estate recovery provision because it trips up a lot of people, especially in terms of when you think of generational wealth. Oftentimes the only wealth a family has is the house. And so a lot of our clients need the care, want the care, qualify for the care, and they'll say no because of the estate recovery. Now, saying no does not mean the need goes away, okay? They're still sick, they're still at home, they still need care, they just don't want to give up the full value of their home. And inevitably that means they get sicker and sicker, and then they end up in the hospital. They probably at some point have to go on Medicaid to pay for their care. It doesn't really accomplish anything, but it does trip people up in not wanting to go on Medicaid because of this estate recovery provision. So there's talk every time the legislature meets about getting rid of this provision, but for now it's there. Yes?
How do they look at, like, if, your parents, passed away and left you an inheritance?
So whatever money exists in your account at the time you apply for Medicaid is considered an asset or a resource, unless you got it in some sort of protected trust vehicle. If you, in an example of someone who had Medicaid costs and then had stipulations in their will as to inheritance for family members, the state of Washington is going to be first in line for recovery. So the executor would get a notice and would have to follow that in terms of who gets what out of the estate, because the state of Washington is gonna get their
Now,
money back.
what if that money isn't there anymore?
If it's not there, then you're fine.
Okay,
You're there, yeah, you're fine.
like if you received it and spent it, you know.
Exactly. Now, keep in mind though, if you were on Medicaid, get the inheritance, once it hits your bank account, you're probably not gonna be Medicaid eligible anymore. because-
Yeah, but say like
But-
there's a,
Yeah, but you can go ahead and spend it for your own personal need all you want.
yeah.
Yeah.
And then, but like say 5 years has passed, you know, and you're going into the Medicaid.
Exactly, yeah. So I've had some very savvy people who have dispensed with assets very early on in their life to reliable family members. I actually had a couple I met a few weeks ago who was asking about Medicare, and they told me their plan. And like in their 50s, they had signed over a house to their son. They had dispensed with money out of a bank account into another family member's account. I mean, they were very savvy. They were far now past the look back period. So that was their planning. I wouldn't suggest that you kind of solo it. I would suggest you do that with some planners that know what they're doing, but some people really are thoughtful about stuff like this, so. Okay, so this is where it's gonna get even more confusing. There's different types of Medicaid. There's what's known as modified adjusted gross income Medicaid, also as MAGI. There's supplemental security income Medicaid, SSI. There's clients that can have both Medicare and Medicaid. We talked about Medicare. And there's Medicaid programs where you're eligible based on your functional need, such as care in the home, such as care in a facility. So if someone were to tell you, I know there's one pathway to Medicaid, that's completely not true. There are multiple pathways. If someone were to tell you, your income has to be this to qualify and your assets have to be that, again, that's not true. It depends on need, it depends on your age, it depends on situations. It's very complex, okay? So being an expert in Medicaid means you're gonna tell a person it's quite dependent upon your situation, financially and functionally. So Washington modified adjusted gross income Medicaid is linked to income only, okay? So right away I'm confusing you, right? Because I said income and assets, right? Not in Washington if you're not on Medicare yet and you're an adult. So this is new from the Affordable Care Act passed under President Obama. It's not reviewed for disability or resources or functional need. Many states chose not to offer this expansion. State of Washington does offer this. So what does this mean? This means if a young man or woman were to walk into our office and say, hey, I'm not working, I'm getting by just fine, I saved up a few $1,000s, I'm taking a year off. What do you got for me? And I'd say, well, one thing, we could apply for basic food for you. You don't have any income, so we could probably get you on a basic food benefit. There's no asset test or functional need on that. And then we could tell you, we could get you on Apple Health Magi Medicaid as well. Really? Like, yeah. Well, what does that do for me? I said, well, it simply pays 100% of your medical costs. That's what we could tell you. And he's gonna say, don't I have to be disabled? No. Don't I have to prove need? No. So this is what Magi is. And I tell people that because the Medicare world is not that for Medicaid. It's not that, but for other people, it is that, okay? So if you've got a friend or family member who's in a situation like that, they should call us because we can get them on medical coverage. It's surprising to me there's still folks not on medical coverage because even with some income, I think the Magi Medicaid income level, I think I have it in here somewhere, it's like $1,700 a month. So that person could even be working half-time and still qualify for medical. And even beyond that, there's a healthcare marketplace where people can get some very cheap coverage plans. So keep that in mind. Again, this is sometimes you read stuff and you're like, wow, what's going on there? The state of Washington is incredibly generous when it comes to healthcare coverage. I mean, I'm gonna say that just as an observation, incredibly generous. Most people walking around sick or well should be eligible for Medicaid coverage, okay, if they need it. Traditional Medicaid is linked to aged, blind, and disabled status. That's what it was when I started working here 20 years ago. You had to show age, blindness, or disability to qualify. This new Magi category, you don't need to show that. The Magi program provides health care coverage to ages 19 to 65, not incarcerated, not on Medicare. So, as an example, if someone in the room told me, well, you know, I retired 3 years ago, I'm 62, I wanna go on Medicare at 65, I saved up enough money, I didn't like my job, what can I do? I would say, well, you're in great shape here, because I can get you on Magi Medicaid for the next 3 years. Well, what happens when I turn 65? You gotta go on Medicare. So you're gonna get a letter at 65 or soon before from the state saying, oh, by the way, you've been loving your Magi Medicaid, you're losing it now. And then people call us and say, wait a minute, I don't wanna go on Medicare, I wanna stay on my Magi Medicaid, and we tell them, tough luck, you gotta go on Medicare. If you're Medicare eligible, you have to take it. And the reason people don't like that is because Magi Medicaid is more generous than Medicare. Now, it's more restrictive, but it's more generous, okay? So here's an example. Joe, age 27, no income, has $5,000 in the bank, which he saved when he was working, quit his job, needed to be a live-in caregiver for his mom, not planning to return to work since he needs to stay home to care for her, not disabled, not receiving any disability or SSI benefits, applies for Magi Medicaid, is approved, simply because he has no income, even though he has resources. So there's definitely situations where this is a big benefit, where in the past, we couldn't get people on healthcare coverage. Now they can get it. So here's an example of what's a real benefit for someone to do that. It requires no premiums, no deductibles, no co-pays for any covered medical or pharmacy benefits. A state recovery only applies if you're 55 and older. There's no look back period because we're not looking at assets or resources. Effective July 1, these are where the income limits are: $1,677 a single person, $2,268 for married couples. So again, if you've got someone, young person coming out of college, can't find work or not working, they're worried about healthcare situations, maybe they're disabled, not on Medicare yet, whatever the case might be, please have them call us. We can get them on Magi Medicaid pretty easily. It's a different pathway than traditional, but it's still available, so. Okay, like I said, age 65, that changes. You move on to Medicare, you take Medicare, you have to, whether you age into it or on disability, you must take it. Even if you don't take it, the state is gonna have a register that you should have taken it. So again, we have people who just ignore the notices, they lose their Magi Medicaid, and then they're late applying for Medicare, they're gonna be penalized. So this is the big difference. So say up to year 64, 11 months and 29 days, you're on Magi Medicaid. Boom, you hit 2 days later, you're not on it anymore because the state's gonna say you need to go on to Medicare, okay? So 2 very different programs. Okay, what about SSI Medicaid? For those of you who don't know, supplemental security income, that's for folks who are considered categorically needy because they never were able to work, they had an early disability, they were never married to anyone who worked, so they qualify by being aged, blind, or disabled. So at a young age, if they have no work history, they can still qualify for this program. If they qualify, they automatically get Medicaid coverage. They get $914 a month, that's all they can get. For a married couple who are both on the program, $1371 a month, but now we're jumping into the asset world. $2,000 maximum for a single person, $3,000 in a married couple. They'll always be eligible for Medicaid because that's the standard, $914. That's the most you can get on SSI. So sometimes we'll talk to clients who never did a lot of work or were married to someone for a short period of time. They get to their Social Security life and they're only getting $700 a month. They'll call us, what do I do? So again, we'll apply for basic food and we'll say, have you thought about SSI? We can get them on that. That'll jump their $700 to $914 as long as they have less than $2,000 in assets. They can still own their home, belongs in the home, but they can't have more than that. So this is where it gets very restrictive in the state of Washington to qualify in certain categories because of that $2,000 asset limit. And then they are allowed to own exempt resources and still remain eligible, burial plans, homes in which they live, personal belongings, and cars. So that grant amount's gone up gradually over the years. It's still very low, so it's unfortunate. We do have some seniors, that's all they get income-wise. They're struggling. We've had seniors that in the last few years have gotten $200 a month rent increases, $300 a month rent increases. We have no way to add money to their income. So this is why it's so much difficulty with housing right now because there's a new building going up near my house in the Proctor district of Tacoma. They're micro studios, 240 square feet. That's like the size of a dormitory room, $1,600 a month.
Wow, stupid.
Clients are never gonna qualify. There's basically nothing we can find them for which $914 a month is gonna qualify unless they're in some sort of a rent, income-based rent apartment building. That's what we need more of, or income-based rent apartment buildings. Otherwise, these folks are never gonna find a place to live, or never gonna be able to keep a place to live, because everything's more than $914 a month. I don't know what's typical out here, but it's gotta be over $1,000 a month for a basic apartment right now. Very difficult. Okay, so can you have Medicaid if you're on Medicare? Yes, but you're jumping into a very low income situation in most cases. There's different limits depending upon what program you're on. We call a full Medicare Medicaid client a dual eligible. They have traditional Medicaid, not MAGI. There is a 5-year look back period. There is a state recovery. So once you're in the Medicare world, there's a lot of strings attached if you add Medicaid to it, okay? So that's a very confusing and puzzling thing for folks, but that's the situation. These clients are eligible based on income and resources, so you can have Medicare, but it drops back to the standard we talked about on SSI, a little higher for a married person. So if you're to come to me and say, Matt, I've got $1,200 a month income, I'm on Medicare, what do I need to do to get on Medicaid? You're gonna be over the income limit. That's the first thing I'll tell you. And then if you tell me I've got $10,000 in the bank, I'm gonna say you're gonna be over the asset limit. And then you're gonna say, well, wait a minute, my grandson, he's 25 and he's not doing anything and he's on full Medicaid. What's the deal? And I'm gonna say, well, that's because he's not on Medicare and you are. And that's just the way it is. Again, you can keep the same resources, belongings in the home, burial plans, things like that, cars. You just can't have additional resources or assets that are considered liquid. So that same person, if they told me they had $1,200 a month income, we would apply for Medicaid, it'd be denied, but we would be told your client's on a spend down program. That means they would need to show expenses out of pocket that are above that 914 level that takes their income down to that level. This is a program that's very complex, very few people meet the standard. If you've got a friend or family member that wants to know more, we can give them the information, but more often than not, after discussing with that client, they're probably gonna tell me they don't have those expenses, because most people don't, because they don't chase expenses they can't pay. So it's really a conundrum puzzle program when it talks about spend down. Okay, so what if you need long-term care at home or in a care facility due to limited income resource and due to a functional need for care? So we're assuming in these married couple descriptions, when I talk about them, that that's one of the partner spouses that needs care, not both. So that's gonna give us a little bit more guidance, and more often than not, that's the case that we encounter. So if you were to come to me and say, Matt, my mom needs care at home, what can we do for her? We can't pay $35 an hour, so we would look at the COPES program first. We would look at this program that provides the most hours and the most coverage. The care hours, depending upon your mom's needs. The care can be provided by an agency or you as the daughter or son and get paid to provide the care as long as you do a fundamentals of caregiving class and pass a criminal background check, okay? So that's the COPES program. We'll talk about that first because that's the one we always think of first with clients. Single person can have income up to $2,742. So if your mom, you tell me, has income of $2,500 a month, good, we're good on income. Spouse of a married person can, on COPES, can keep all of their income. So if you were to say, yeah, but my dad has a good Navy pension, he gets $33,000 a month, I would say we're still good because we don't look at the spouse's income, we only look at your mom's income, okay? So we're good there. The single resource limit is $2,000, the married resource limit $60,000. So if you were to tell me mom and dad combined have $50,000 in the bank, they own their home, the bonds, we're good. You can still get services for her. She's not gonna have to pay anything for the services because she's under the max. And then you're gonna ask about estate recovery, and I'll say, well, yeah, your mom's over the age of 55. So for every dollar she's billing out on her Medicaid services, including the caregiver services, that's gonna be tracked by the State Office of Financial Recovery. And then they're gonna ask, what does that mean? I'm gonna ask, again, tell them, every dollar is tracked by the Office of Financial Recovery. So if mom were to go into an adult family home, Medicaid pays a lot less than if you were paying for it privately, but still, mom's gonna be clocking in probably $3,000-4,000 a month on Medicaid services. That's all being tracked by the Office of Financial Recovery. And she's gonna have to be found eligible based upon her functional need. So if mom just needs some help doing housework that you're doing for her, we're gonna say no. But if mom physically can't get dressed in the morning, she can't safely shower on her own, she needs periodical help with some sort of body treatments or things like that, then we might be able to get her approved. So income, assets, and functional need for that program. Does anyone know anyone that's been on this caregiver program, coach program? Again, this is one where we could actually pay the family member to do the care, and it has to be a non-spouse. Yes,
Who determines?
the functional need. So we can help with the application and the screening. It's actually the Department of Social and Health Services Home and Community Services Office in Tacoma that will send a social worker out that does what's known as a care assessment to determine what the needs are. And from that assessment, they're either gonna produce a number of care hours in the home, or they're gonna produce a daily rate for facility care. And the reason so few facilities take Medicaid pay, because it pays about a third of what private pay would be. So there's many facilities, I would say, who don't even consider it. So you couldn't go to one of these fancy new buildings going up around town that has memory care involved in there and say, hey, I wanna bring my mom in on Medicaid. They're gonna say, we're getting $8,000 a month private pay. We're not gonna take your mom at half that. Tough luck. So then you'd have to think of going into Tacoma, where Cascade Park Gardens still has a Medicaid funded memory care. It's the only one. We only have, I think, 3 assisted living facilities that take Medicaid. Fewer and fewer adult family homes take Medicaid. Some of them will take you after you've paid privately for a period of time. So they'll say, well, you sign a contract, you pay us a year's worth of care, sometimes up front, and then they might take you on Medicaid after a year. Yes.
What was the name of that facility again?
Cascade Park Gardens. So this is the problem we're running into, is because we don't have enough facilities that can manage with the low daily rates they get paid by Medicaid. Yes.
There's a statement here, clients may have a financial participation if their income is above the single or married
Yes,
income limit.
yes. So let me go back. That number there, 2742. So if that client's mom was at $3,000 a month, we could still get her on the program. She would have to pay that extra every month to her agency for her care.
And that 2742, is that a gross amount?
Yes.
Like from your
Yeah,
social security?
Yes, it's the gross amount you get on your social.
Before your Medicare
Yes,
premium is taken out?
but when you go on the program, that puts you in that Medicare savings category automatically, so that premium gets put back in your check. Just to add to the confusion, different than the standard I showed you. So,
No, I mean, that's why I'm looking at coming down.
yeah, I'm sorry, it gets very confusing because there's little changes in track
Because
order.
we're at this stage right now.
Now, the good news on that number is even a year, it was July of 22, that number was closer to $1,300 a month. So they jumped it up dramatically. They finally recognized how costly it is to live in the state of Washington.
So they have more than just one functional need. They could have several.
Yeah, so we have clients that go on in-home care that get 30 hours a month of care. Some get 160 hours a month. Very rarely, they might get 24-hour care. They're very, very limited. More often than not, the state will find a tipping point there where they'll say, instead of paying this amount for you to get care at home, we'll pay for you to go into a care facility. And that gets tricky because we have very few choices on care facilities, and there's a huge demand for them. So again, it all goes back to needing more Medicaid beds and trying to make that happen, but the state doesn't manage these facilities. They're privately owned, some by nonprofits, some by charitable organizations. And we know how valuable real estate is, right? And so, you know, if you're a proprietor and you have an adult family home, you might have been in the business forever, maybe your kids don't wanna take it over. But you know, that home's probably worth $600,000-700,000 now, you're gonna say, hey, I'm done, you know, I wanna get rid of it. Then it becomes something else, and so this is the problem we run into, is there's just not enough funding that's paying a higher amount for people to be in these care facilities. And what we're hearing from the social workers is that when they even send the referral over and say, here's your dollar amount rate, the facility, even the ones that take Medicaid, are often saying, we need more because this client has a lot of needs and we're just gonna need some add-ons to take care of them. So this is the challenge. Again, this is something where you wanna have in the back of your mind, this is something we need more of. It's great to increase demand, this dollar number increased demand. We just don't have the supply. We don't have caregivers working at agencies to the extent we can serve people. And then that walk cares is coming down the road here in 3 years, where there's gonna be more people needing care and having money and gonna say, where's my caregiver? And so this is an issue. We need more supply because it's not just caregivers in the home, it's facility caregivers, it's hospital worker caregivers. So COVID really interrupted a lot of this because a lot of people were done with that career after dealing with COVID. And so we lost a lot of quality people just because of the stress and all that.
And they get paid very low wages.
Absolutely, yeah, the reimbursements are very low, and so every grocery store is hiring, right? Every retail store, every restaurant, so if you're looking at, you know, making tips and dealing with friendly people versus dealing with some very difficult people and doing a lot of nasty stuff as a caregiver, I can't blame people for wanting to not do it. So if you ever have the opportunity to really ask about that and encourage folks about it, we've been trying to build up programs even at like the Tacoma Community College level where they can have certificate programs. There's even been discussion about, you know, we've a lot of talk about student loan paybacks and maybe having an opportunity for people that put in a year's worth of caregiving services to get some opportunity to take some of that money off their loans. There's a lot of been discussion, but it's still a big problem right now. Okay, so to confuse everyone even more, there's another Medicaid program for in-home care with a higher income limit, $36.56, and a higher resource limit that was created a few years back in order to serve people who weren't COPS eligible. This is only 20 hours a month of help though, that's the maximum. So the most you can get is 20 hours. No estate recovery, no look back period. So what we were finding is we had people with higher incomes, higher assets, didn't want to go on COPS or couldn't, didn't want the estate recovery, hated the look back period. And so this is kind of a stopgap program the state created, 20 hours a month of care for people that otherwise wouldn't be eligible for COPS. It's not enough care for many of these clients, but it's something rather than nothing. And again, we're running into the caregiver issue there. People don't want to work for just 20 hours a month. They want to work for a lot more than that. So we have trouble staffing these cases because there's just fewer caregivers that want to take on that work. But it is available. So again, higher income, higher assets, no estate recovery, no look back period. And now let's jump to the facility side of things. So we talked about in-home care. This is Medicaid in a care facility, all right? The cost of the care depends on the monthly payment rate as established by the social worker doing the care assessment. So again, we're looking at income eligibility, asset eligibility, and then functional eligibility. The monthly payment rate is the amount of Medicaid payment that the assisted living, ALF, or adult family home will receive over the course of the month for caring for that person, usually much lower than the facility private pay rate of what we just talked about. So again, they may tell you, yeah, your mom can come into memory care, $8,000 a month, you sign the contract, you tell us you're gonna pay that for a year, or they may even ask you to pay it up front. Then we'll see about putting her on Medicaid. If you're in a situation like that, again, I would strongly advise you to talk to an elder law attorney, find out what kind of binding agreement you can establish with that. Because in the 20-some years I've worked at the county, facility managers change, facility ownership changes, qualities change. So there's a lot of moving parts when you're thinking about this type of strategy. If mom went into that care facility and she's got $3,000 a month income, the care facility payment is whatever the state establishes. she pays all of her monthly income to that facility and gets to keep $100 a month. So if she has $1,000 a month income and the cost of her care is $3,000 a month, she still just pays her amount less 100, the state pays the rest. So this comes up a lot because a lot of family members say, oh my God, they told me it's $5,000, $6,000 a month. She doesn't have that income. You're gonna need to go to a Medicaid facility. She's gonna need to pay her income to that facility. She gets to keep 100. You're not on the hook for it, but $100 a month, maybe it's enough to cover new clothes and things for her. Maybe you're gonna be paying those things for her, maybe a cell phone cost, maybe a meal or two each month. She's gonna keep $100 and that's it, okay? So that amount's changed. It was $71, they raised that. So again, we're in a situation where the system really does work in terms of it doesn't impoverish people necessarily, but we just don't have the choices that we need. Right now, if you were to call us and say, we need this assessment done, we did the application, it could be 6 months before they do the assessment on your mom. Easily 6 months, not unusual. And there's nothing we can do about that. You can advocate, but there's nothing we can do at the county level. It's just a lack of available staff and a huge demand for people needing these assessments. So just keep that in mind. You're gonna be pretty limited on what you can do. Does that formula make sense to people? Because if she goes in as a private pay, she's gonna be paying a lot more than that because they're gonna charge her her private pay rate. But if she goes in as a Medicaid client, the state's paying a lot less. She's still paying her amount and keeps 100, but you're not on the hook as a family member. Nor are you necessarily on the hook as a spouse because they have some allowances for you keeping your income as the spouse, plus they have an allocation formula where her income can allocate back to you as the spouse to pay for your housing costs. So the spouse doesn't get impoverished either within certain limits. Okay. Yeah, there is an exception to the rule in a married couple unless there's housing costs. So here's an example. Jean applies for adult assisted living facility care for herself. We help her with that. Her monthly income $1,000. The care assessment determines that the payment rate to the facility is $2,400. She moves in, I apologize, these are old numbers. She moves in, pays all of her income to the facility, less what she gets to keep. It used to be $7,112. DSHS pays the remainder. So she's never upside down on it, nor is the family. She gets a little bit of money to keep every month, but her meals are taken care of, her medications. She's on Medicaid then, everything's covered at 100%. But she doesn't get to keep any of her income either. Now, they don't take her income, she needs to give it to them. So this is why we have that dementia legal planning page back there. Someone needs to be the decision maker, because if mom goes in on her own, many facilities aren't gonna take mom on her own. They're gonna say, we need to know who's your decision maker, because they're gonna worry mom's gonna be unhappy after a month and she's gonna quit paying them, right? It happens, right? So many facilities are saying now, we need to know who your decision maker is. That person needs to come in, witness the financial agreement and agree to be the one we contact to get the payments made. So this is again where planning comes in. Clients call us and say, mom needs to go into care. Who's her power of attorney? Well, she won't let us be. You're not gonna find care for her because they're not gonna take the risk that after a month she quits paying, because they don't take over her payment. This is a myth about Medicaid. I sign everything over to some government entity. That does not happen. You keep control of everything, but you have to have obligations you're meeting as well, so. Okay, and skilled nursing facility care, it's a similar formula. The state will pay an amount, you'll pay your amount to get up to the level where the state's paying the remainder every month. It's kind of an automatic process. If my parents had qualified, they would have qualified on income, they didn't qualify on assets, but it would have been the same thing. They could have stayed at that skilled nursing facility with long-term care, custodial care happening. It's not unusual that clients run into this. They still need to be in the skilled nursing facility care like my mom did, but she's not Medicare eligible anymore. So the first thing they said to me, do you want to do a Medicaid application? And I knew we weren't eligible, so I declined, but it's not unusual that people will stay. There's some skilled nursing facilities, however, that will not take Medicaid. Families don't know this, so make sure if you or a family member is in the hospital and they say, okay, mom's gonna go to facility XYZ for her rehabilitation from her hip replacement, make sure you ask if they take Medicaid, because sometimes Medicare only, and then it's private pay only. In that case, then they're gonna tell you, come pick up mom on day 21, because they're not gonna keep her longer than that. Okay, that does happen. Okay, I saw a few hands up. Do you have one? Yeah? No.
Second bullet,
Yes.
2,000 a single or 68,000 as a couple.
Yeah, so they basically have an allowance where while the application is happening, they can have combined assets as a married couple of $68,301, assuming just one spouse is going into care. 1 year later, those assets have to all be named into the other spouse's name. So they can start in the process of the two of them sharing a bank account that has $68,301 in it. But after a year, at the first eligibility review, that bank account has to list only the other spouse's name. So that's the allowance they get. And again, this is just because they don't want to impoverish that spouse to nothing to treat the other spouse's needs. That's kind of the way it's set up. But they're happy to impoverish a single person. But they keep hold harmless to some degree the spouse, so. But it's not unusual. We had a woman last year, I think I talked to her. She had been in an adult family home for 5 years, private pay. So that's what, 60 months? I think she'd been paying $7,000 a month. So she close to $500,000 of her estate she spent on her care. And she was still in the adult family home. So they were kind enough that when she was approaching that $2,000 level that they put her on Medicaid, kind enough that they made $500,000 off of her, but still a lot of facilities don't feel that obligation. They would have just told the family she needs to go somewhere else. We won't keep her here, but they kept her there, so. Okay, functional need again, there's different functional need for different levels of care, adult family home, assisted living, skilled nursing, estate recovery provisions are there. During the first 6 months of the client Medicaid funded at the skilled nursing facility, here's an exception. They will allow her to keep a portion of the income to pay her housing costs. So going back to that example of the mom, she goes into care, hospital, hip replacement, care facility, rehabs, she's still not doing well enough to go home. If the doctor says there's an opportunity within 6 months that she still might recover, even without us rehabbing her, we're gonna tell DSHS she can keep paying her mortgage, she can keep paying her rent. So again, this is a discussion to have with the facility staff if your mom or family members in that situation. Yes?
Question online, does the Medicaid recipient have a caseworker to help advise on all the details, make sure they remain qualified as tax applied?
Yes, they will always have a financial worker at Home and Community Services assigned to their case. And then they will have a social worker assigned to the facility in which they reside. Or they will have a county social worker working with them if they're living at home. So they'll always have some professional person involved with the management of their care and the financial approvals working with them or working with the family depending upon the person's situation, so this is kind of a hold harmless thing where we let people in skilled nursing facilities not have to give up their apartments or houses immediately. But if you have a house, you go into a care facility, and then there's no determination that you're coming back home, typically the financial worker will approve the Medicaid, but are gonna say that home is now a liquidable asset, okay? And I've heard different things from different financial workers of what that means, but they're gonna have a conversation with you or your family members to say, mom's not returning to home, something needs to happen to that. What that would mean is she stays eligible, but once that home is sold, if there's proceeds, she's off Medicaid at that point because that's money in her bank account and she's over the asset limit. So again, there's a lot of mythology about what happens. Oh, you're gonna need to sign that home to the state. No, you're gonna need to sell it though, because they're gonna say, we're only gonna fund your Medicaid until you market that house and it's sold. And you can't market at $1 billion and try not to sell it. You gotta market at what they're gonna agree is a reasonable market price because you actively have to be attempting to sell it, okay? Otherwise, yeah, it's that $100 allowance that folks have in the facility. This is where, back in the day where a lot of people were smoking, a lot of people wouldn't go into care because $100, $71 is not enough to finance their smoking habit. That became a big issue, believe it, because what's a $50 a case for, what's it, a carton? $50 or something for a carton of cigarettes? I don't know what it costs. So we always would encourage people, well, give up your smoking, one, or go to rolling your own, number two, buy bags of tobacco and roll it, you know, because, yeah, you're not gonna be able to finance a smoking habit with $71 a month or $100 a month. And you probably shouldn't be smoking in care anyway, but we all know family members who have smoked until the day they passed, unfortunately. Okay, more information on all these programs. Washington Law Help has all of the information I gave you for all the Medicaid programs, telling you eligibility, income, assets, spousal situations, exempt and non-exempt assets, resources. Medicare again to call for information there, Social Security. Magi Medicaid, that first category goes through Health Plan Finder. The other ones go through Washington Connection, but we would always encourage people just to call us 798-4600 about that program, family caregiver support, any of the programs we talked to today. Yes.
Another question, does the state require home asset to be sold rather than alternatives like transforming to a family member or converting to a rental income?
So if you're in a care facility, the question is about that family home. As long as you're occupying it actively, or there's a presumption you will be occupying it, that home can be maintained for your use as shelter. There's also a provision that the spouse can continue to live in the home as long as they're able to do so. There's also a provision that a disabled adult child can continue to live in the home. There's also a provision if you've been a caregiver for your parent and living in the home, you can stay in the home. If it's just mom was in the home, mom's now in care facility, there's no presumption she's returning, then it has to be a liquid resource at that point. You can't change it into an investment property. So it would have to be a property then that's liquidable. The provision for shelter is specific to the person needing the care, the spouse of the person, and in some cases, a disabled adult child or a family caregiver. Other than that, you need to liquidate it. And this comes up a lot because we have clients that will downsize, they're living in an apartment, they have a rental home, they go into care, they're not living in the apartment anymore. That rental home is considered an asset then. They can't just say, well, that's my income. No, that's an asset then, and so you have to sell it. And again, elder law attorney, we have lists of those. There are legal ways under the Medicaid system in the state of Washington where you can do estate planning that helps to shelter some of those assets. You would want to talk to an elder law attorney about that long before you need the care, long before. So now would be a good time to start, so. All right, any questions? Yes.
Under Medicare, can you talk about IRMA, the income?
Yeah, so IRMA on Medicare is where they determine that you fall into a higher income category to pay both your Medicare B premium and your Medicare D premium. They actually base it upon the year prior to the year you're applying on your tax return. And so there's typically a 1-year lag though. So if you're looking to apply in Medicare this coming next year and you had some significant higher income this year, they would not know that based upon this year because it's going to be slow going into their system. They would probably base it on the year of 2022. And then they would assess an additional amount for you to pay on your Medicare B and D premiums based upon a higher income category. So I'm not sure there's stuff in the Medicare and You handbook about that. I don't know if there is.
I didn't see it there. Somebody told me that if you make over 194,000.
Yes, it's based on earned income, I believe, but I think it can also be based on proceeds from the sale of assets as well. So you might want to look on Medicare.gov about IRMA. I'm not an expert in it by any means, but basically what this means, what she's asking is that on certain higher income levels, they